Good morning to you. Today I am going to talk to you about burns, which is a very important topic. Because burns are important. Why? Because it inflicts injury, and after that also there may be lifelong complications in disfigurement and cosmesis. The cosmetic aspect. After all, the human body is a very precious body. And sustaining burns is a tremendous amount of morbidity and sometimes the mortality also. Morbidity means a disease which affects the human beings, and mortality means the termination of life due to disease. Okay? So it is quite frequent in all age groups and both the genders, right? On all the genders, this is not so uncommon. What are the agents which can cause burns? It is maybe hot thermal burns, and there will be cold thermal burns also. If you go to high altitude and a cold climate with temperatures freezing -50, 20 degrees centigrade, and one gets exposed to wind chill factor and the snow, that means this may cause cold injuries in the form of frostbite. But hot thermal burns are caused because of maybe a solid hot object has struck the body and a person has come in contact with the fire. It's a solid I am talking about, solid structure which is very hot and has come in contact with flames due to fire or flames while working in an industrial complex. There may be hot thermal injuries, burns because of liquids also at boiling point, like water. In children you find they sustain burns and scalds while they are in kitchen or something as boiling. It has the boiling milk has fallen on the child, so it will cause injuries which are called scalds, SCALDs. What are these called? These are called scalds. Over and above this, there are the physical injuries to the body, which is quite manifest. May involve the skin, it may involve the deeper structures, it may involve the superficial structures. Is that clear? And not only that, when there is a fire, say a person is traveling in a car, or there is a fire in some industrial place, there is a fire in a theatre, there is a fire at home even, and then a person is exposed to intense heat of the flames, right? Not only that, when there is a smoke, a person may or might have inhaled the smoke, the hot smoke going inside along with the soot, the burn particles, small particles may cause damage to the respiratory epithelium. You get the point? And with the burns, other organs may suffer because of its ill effects, right? So the agents are many which can cause burns in a person, right? So what are the types of burns? Now you should write this. Generally we classify burns. Listen to me carefully. We classify burns. We have to see, number one, the timing of burn. What time the patient will come to you, you have to ascertain what time the patient sustained this hot thermal injury, right? And what is the duration between the sustaining injury and being brought to the hospital? When did it occur? What is the time frame? Right? 2. Then we have to ask the patient, what is the contact time with the flames? How long he has been exposed to fire, or a hot liquid or hot fluid? Or it might have been, the burns might have been due to electricity, electric burns they are called. So we'll discuss all these things. If if you have plenty of time, what I am talking to you is going to help you in pathology also, surgery also, medicine also, and things like that. So it is going to help you. And once you listen to the talk carefully, you can divert the attention of the teacher, the examiner, to a topic subject which you know the best. So your tendency should be to, today you are listening to my talk on the verbs. So therefore, you should always have a tendency should be that somehow you draw the attention of the examiner to what was asked you, the question about the subject which you know the best. You understand? That's the point. I was talking to how do we classify verbs, what are the types of verbs, right? So types of verbs, let us say first of all, there are hot thermal verbs, cold thermal verbs, and electric verbs. Take it? There may be scarce, and there may be external verbs, there may be internal verbs, right? There may be external verbs and there may be internal verbs. External verbs means then your skin surface is affected, but then there are verbs which occur because a person has swallowed some corrosives like alkalis or acids. You get my point? So, but externally I am talking about to you, the verbs depend upon the duration of contact with the fire or whatever it is, agent, duration, and then the extent of the body which is involved in the verbs. Is that right? And what is the depth of the verb? The extent of the verb, I will speak again till you aapko yaad ho jaye. Extent of the verb, the timing of the verb, the depth of the verb, right? And the contact period. As you know, the skin, what is the function of the skin? Skin is the most important organ which is affected most by verbs. Is that clear? So, skin has what are the, basically we should know there is an epidermis. Isn't it? There is the epidermis, there is the dermis. And then, what? Then you can simply say there is the epidermis in the skin, there is the dermis, and subdermal tissue is there. So epidermis has got what? The epidermis, basically the point of reference today is we have some appendages in it which come out of the epidermis. What are these appendages? They are hair follicles. They are hair follicles which are in the epidermis and in the dermis also. So what are the hair follicles? They have, sebaceous glands attached to it, isn't it? Sebaceous glands which keeps the skin moist, right? And prevents the skin from getting invaded by microorganisms. So we have hair follicles, we have sebaceous glands, and we have tubular structure which is called sweat glands. It's a tubular structure which extends right not only to the epidermis but goes into the dermis also. Is that clear? So these are the basic things. So whenever a person sustains burn injuries, it may be partial thickness or it may be full thickness. What did I say? You write down partial thickness and full thickness burns. Partial thickness and full thickness burns. Now partial thickness burns we have divided into superficial, partial thickness burns. What did I say? Superficial partial thickness burns and deep partial thickness burns. What did I say? Superficial partial thickness burn and deep partial thickness burns. And then comes full thickness burns. The third one is full thickness burns. Now let us discuss each. each type of bulb. Superficial partial thickness bulbs. It may be, just a person has come in contact with the hot object or the hot liquid or whatever it is, right? Superficial partial thickness bulbs, they may be so superficial that patient has got only the skin becomes red and painful, right? And you see that the skin is supplied by extensively with it has got soul circulation also, it has got nerve supply also. So therefore, in superficial bulbs, particularly the surface bulbs, the skin becomes red, and therefore there is a swelling, there is redness, and patient has got intense pain because nerve endings are exposed, because epidermis is not destroyed, right? So in superficial partial thickness bulbs, the depth is limited, but however, because of involvement of the nerves, the pain will be severe. Superficial partial thickness bulbs. Is that right? And these bulbs, superficial partial thickness bulbs, there is a damage to the superficial epidermis. So, since the appendages, hair follicles, sweat glands, which these are epithelial cells, they are intact. There is nothing wrong with them, right? This is the epidermis, this is the dermis, and this subdermal tissue. So here you find that the hair follicle, there is the sebaceous gland, and there is the sweat gland also. So involvement of this part of epidermis will still, these hair follicles, sweat glands, sebaceous glands are intact, and therefore patient becomes all right within 3 weeks. 3 weeks without any cosmetic deformity, right? Without any scar, right? Now we come to superficial partial thickness. The superficial partial thickness, again, the superficial epidermis is damaged, appendages of skin there are intact, right? But the bulb will extend right up to this place, in which the hair follicles, which is red, and sweat glands are damaged. So, still the wound will heal, because some part of, now this is in the deep partial thickness, some part of the hair follicles and the sweat glands are intact. So these skin will heal, but then it will take longer than 3 weeks. You understand that? In superficial partial thickness bulbs, the skin will heal completely, but in deep partial thickness bulbs, the healing will be there, but it will take more time. Then comes your deep partial thickness bulbs. In deep partial thickness, the entire epidermis and dermis is gone, and you have only subcutaneous tissue which has got blood vessels and the nerves, right? So since these are affected, they are injured, so therefore these bulbs will take long time to heal. And how they heal? How these heal? When epidermis is gone, dermis is gone, your appendages of skin are gone, that epithelial tissue is no more there. So these will heal. How it will heal? There is no epithelial element, but it has to heal. So the part around the burnt area which is not injured, epithelialization takes from the margins, from the edge. There is a huge area which is involved. So the epithelialization will occur from the margins of the healthy skin. Is that clear to you? But when epidermis is lost, dermis is lost, and fat is exposed, it might have gone into the muscles also. You get my point? It might have gone deeper. Then what happens? There is no epithelial tissue, so there is a deficiency, and wound will heal by fibrosis, and it will become a source of infection. That barrier, skin barrier is gone. Skin is a barrier against microorganisms. Sweat glands are secreting, water and electrolytes. Sebaceous gland is secreting sebum. So skin is kept, the integrity of skin is kept intact. But in deep partial thickness burns, if it is destroyed, epidermis and dermis is destroyed, you are left with no epithelial tissue. You understand what I am saying? And it heals by fibrosis. Once the fibrosis is there, it will contract also. There will be contractures. You might have seen contractures that over the joints, a person is not able to move a joint because healing has occurred by fibrosis and muscles contract. There is intense fibrosis, and therefore there is a bad functional results of the area. You get my point? The margins cannot complete the entire broken area, that ulcer area which burns, and therefore the healing occurs by fibrosis, which results in contractures. And over and above these burns, if there is an infection, if there is a sepsis, so the wound will take very long time. Okay? So, I will repeat again, we have partial thickness burns, full thickness burns. We have superficial, partial thickness burns, and deep partial thickness burns, and we have got full thickness burns. Right? Now, once a person is injured, you want to formulate a planning. Planning for what? Treatment. And for treatment, you must know what is the extent of burn, what is how much is the depth of the burn. Right? So how do you assess all this? There are various formulas. The simplest one is when any part of the body is burned, you have to, for the sake of assessment and treatment, you must know what is the extent of burns. So what is the extent of burns? There is a formula which is called formula of nines, N-I-N-E-S. What is it called?
Formula of nines.
Entire body constitutes 100%. Right? Out of 100%, we want to see what is the percentage of the skin which is involved. So this percentage is found out by a formula which is called formula of nines. Or what is formula of nines? Or is formula of this. You see my hand? This is the palmar surface of the hand. And when you open your hand like this, you see the fingers are like this, and you make an impression on a paper, you cut it, the paper you cut. Right? A burnt area you cannot touch with your hand. Can you touch it? No. You have to put on the gloves. Right? That we'll discuss later, how to prevent infection, things like that. This is the hand, palmar surface of the hand. So the size of the palmar surface of the hand and constitutes 1% of the burn. How much? Suppose the skin involved is the size of my palm and palmar surface of the fingers, digits, that constitute how much? 1%. So you cut a piece of paper, plain piece of paper, and measure with that. So we'll know this is 1%, 10%, 15%, 20%, 30, 40, 50, 60, 70, 80. You get my point? You have understood this point? This is called this is 1% only. Right? The other one is formula of nines. Nines means adults. Nice. What is that? Draw a human figure like this. This is the head, this is the neck here, this is the upper limb here, right? This is the, you can say, trunk here. These are the limbs which is active. So, head and neck constitutes 9%. How much? 9%. 4.5% for the front and 400% for the back. Is that right? If entire head and neck is involved, you say the patient has got 9% pulse. We have not decided whether it is superficial burn or is a deep burn. That we will discuss later. Never mind, let's go slow. No, we have been told by the old MCI that repetition, right? Head and neck is involved, so this makes how much? 9%. If the upper limb is involved, it makes 9% and 9% each side. Front portion 4.5% and back portion 4.5%. Is that right? So 9 for the head and neck, 9 for upper limbs each. Each liver limb involved entirely with burns, it is 18% both. Then your trunk from neck to pubis, right? The front portion is 18%, the back is 18%. Is that right? Then come the lower limbs. Each lower limb is worth 18% and 18%. Is that right?
18 for one.
Yes, yes. And 1% is for the perineum. 18% for the front and 18% for the back. Is that right? 1% for the perineum. Now I'll repeat again. Now it's a very simple thing to understand very well, but still let's talk about it. 9% is for head and neck. 9% is there for each upper limb. 18% is there for the front of the trunk and abdomen, and 18% for the back. 1% is there for the perineum and 18% front and 18% back of each lower limb. So how much it makes, please find it out. It makes 100%, right? Calculate it. How much is it? It should make 100%. Simple. 9%, 18% front, 18% on the back, 9% right upper limb, 9% left, and 18% front of the thigh, lower limb, and posterior part 18%, 1% for the perineum. Is that clear? So that makes the extent of burns. Now, since if you calculate the weight plus total body surface area, what did I say? Total body surface area percentage. Total body surface area involved by the burn plus the weight of the person, if it is more than 80, is a likely candidate for death. That is imminent, possible. But these days, in some of the countries, people have been saved who have got 100% burns. Burns is a dreadful disease. It's a very unfortunate injury because mortality rate is very high. Patient is conscious till last, I'm telling you. We can't do anything because some people died due to burn shock because so much of once the skin barrier is gone, there is a fluid loss from the body. And you know that a lot of fluid is lost and there is no fluid plasma left in the body. It has gone out, exudation, right? So over and above, unless we have total barrier nursing in this, we have excluded any, there is not a single bacteria can come inside. The man himself has got, human beings themselves have got organisms in their body, nasopharynx, oral cavity, urinary tract, surface of the skin. He himself becomes a source of infection. You get my point? But even if you eliminate totally the infection in the burn unit, that's why you must have an exclusive dedicated burn unit for the management of burn patient. He cannot be managed with the ordinary crowd in the general ward. He will get infection and die. Exclusive dedicated staff. You get my point? This I will discuss this in management. So what I am trying to tell you that burns cause damage and morbidity, the person will get disfigured, stays in the hospital for a long time and might die. Therefore, any person in our country, unfortunately, we have seen that persons who have sustained 50% burn, 60% they die. They die because of septicemia, infections, organisms, mixed infections, hospital-acquired infections. Hospital-acquired infections used to be called as nosocomial infections. He is getting infection from the slithering end, getting from somebody. So therefore, a person who is treating them, they must be covered fully with gloves and garments and hand wash and everything you have to follow. Total antisepsis and asepsis is required. You get my point? Otherwise, the patient will die. Once the skin barrier is gone, all kind of organisms will settle down on the muscle mass and the dead necrotic tissue. You can't save the patient. So therefore, what I am telling you, that the extent means, no, I hope you are not getting bored or something like that. I'm stressing too much. One is the extent of the burns, the other is the depth of the burns. Now, how do you assess how much is the depth? 2 centimeter, 3 centimeter, 4 meter, you don't know. Electric burns are very difficult. Electric burns, when the electric current is passing through, it destroys the inner structures, the blood vessels, the muscles, the nerves. Is that right? When it is conducting electricity, so you don't know what is the depth of the burn. So in burn, which I told you already, that if the patient has been brought to you, the skin is red, there is a pain and there is swelling and you show intense pain. What does it mean? That burn is superficial. Any person who is brought to you who has got redness, after burns he has been brought to you, there is redness, there is a pain, intense pain and there is a swelling. That means it is a superficial, partial thickness burns or something like that, superficial burns. Alright? But a person who has got full thickness burns with entire epidermis is gone, the nerve endings are destroyed. And he has no pain, that means it is full thickness burns. Another thing is that if you press the skin, superficial partial thickness burns, the skin will blanch. Now look at my skin, it's red. So I pressed it, there is a blanching and color returns back. When you press the skin, there is a blanching and the red color comes back. That means the capillaries are intact. What are intact? Yes, there is a blood supply. So that is superficial burns, superficial partial thickness burns or whatever it is. Right? But in those patients, in home you don't find there is a patient is not having pain, he is not doing but no pain, less pain. And the skin over this thing, whatever needs, fresh case, the burn is deeper and skin does not blanch. Skin doesn't blanch. That means it is the thing. And not only that, when the skin, the subcutaneous tissue is gone or something like that, and you can see the veins, we can see the vein, and the skin has become, which is, you can say dead, it is whitish in color and it is woody. लकड़ी की तरह सख्त हो गया, ठीक है? is as firm as a wood, as hard as wood, that means it deep burns. What is that? That means burn is deeper. Is that clear? Shall I repeat it again, or you have understood about it? Okay, now let's proceed further. Pathology. There are local effects on the skin and there are general effects. What are the local effects? If the number one is superficial burns, there will be redness and swelling, right? Which will heal itself within 3 weeks or so. But in the deep burns, what will happen? The vessels may be destroyed in the burns, and there is a soft tissue becomes whitish, woody, or color changes are there, something like brownish. It is, that kind. This dead tissue after the burns is called eschar. What is it called? You have heard about eschar? E-S-C-H-A-R. E-S-C-H-A-R. Eschar. Eschar. This dead tissue after burns, which is white, woody, again, that tissue is called eschar. What is it called? Eschar. And it will cause fibrosis. It will cause fibrosis. What will happen? It will compress the blood. Suppose there is a worm all around the circumference. Deep burns. What is going to happen? There is an eschar. When it heals, it might create a tourniquet effect. What it will? You have heard about tourniquet. Tourniquet. T-O-U-R-N-I-Q-U-E-T. Tourniquet. What is tourniquet? किसी को रस्सी बांध दो, somebody is bleeding, there is a cut, people used to tie a rope here so that patient doesn't bleed. This is called tourniquet. Tourniquet means you are applying a pressure bandage, a very tight one, to arrest the hemorrhage somewhere. That is called tourniquet. Now we take blood pressure when we are inflating the spigometer, and to measure the blood pressure, it compresses the arm and blocks the brachial artery here. Brachial artery, by the way, what is the anatomical location when you want to palpate the brachial artery? Where is it?
Cubital fossa.
Why? The cubital fossa. Don't talk like this. Brachial artery. It's a continuation of the axillary artery. It is in the elbow. This is the tendon of biceps brachii. Just medial to the tendon, you palpate. The artery is called brachial artery. So therefore, when you apply a suppose there is an injury, person is bleeding, you want to rest the hemorrhage. One is the compression banding. The other one is that you apply in olden days. People used to apply this to stop the bleeding, apply a tourniquet, some tight rope or something like that. So it has a tourniquet effect. That means to stop the bleeding, you are occluding the brachial artery. But at the same time, when you are applying this tourniquet, you are occluding the venous drainage also. You get my point? You are blocking the veins also. As a result, there will be no drainage, no lymphatic drainage, everything is blocked. And so therefore, distal to the tourniquet, you have swelling. You have a swelling. And since you have blocked the brachial artery also, you start having gangrene, that you have to do the amputation, I am telling you. So eschar is the same thing. Formation of eschar will cause tubercular effect. Now you understand what is tubercular effect? When you tightly apply some kind of a device, it will obstruct the arterial blood flow and the venous return. So it is a double effect. So it will cause redness, swelling, and gangrene, black in color. You know what is gangrene? It is death of the macroscopic part of the tissues. Gangrene, color. Gangrene is a non-living tissue that no alternative except to amputate it, otherwise instead further extension. So eschar is one of the presentation of the deep thermal burns, right? Then, what are the other pathologies? What is the other pathology? That fluid will come out of the vessel. Vessels are damaged. Vessels are damaged in
Deep, deep.
A deep burn. So therefore, there is leakage of fluid plasma from the blood into the interstitial tissue. Once the plasma and fluid is coming out of the capillary vessels, because they are damaged, it's leaking, it will get collected all around, causing a swelling, which is called edema. If it is in the leg, if the leg circumferences afterwards increases by 2 centimeters, please listen to me carefully. If the leg circumference increases by 2 centimeters after the burns, a person has lost 2 liters of fluid into the interstitial space. Is that right? We have got 5 liters of blood. If 2 liters is gone, and if the process continues, what remains in the blood volume, patient will lose the blood volume. But RBCs don't leak out generally, so there will be hemoconcentration. We will give you a pulse and see HB is normal or it has got HB is increased to so and so. Untreated patients. So, what I am saying is that fluid will leak out into the interstitial fluid, causing hypovolemia. Hypovolemia. The volume will go down, and once there is a hypovolemia, what will happen to the patient?
Edema.
Fluid is leaking by edema, and what else will happen? Once the blood volume goes down, patient will go into shock, hypovolemic shock. Hypovolemic shock means person's blood pressure will come down, the pulse will increase, he has a tachycardia. Naturally, tachycardia just to compensate for the demand of the body. Brain requires oxygen and nutrition. Kidney requires kidney requires oxygen and nutrition. Intestine requires nutrition. There is no oxygen. There is no oxygen because there is no volume left inside. The tissue perfusion is poor, and tissue perfusion means delivery of oxygen and nutrition. What are the nutrition the immediate images utilize? Glucose. Everybody wants. The brain said, "I want glucose and oxygen." That is priority 1. So it is diverted to supply blood to the vital organs first. So what happens is when hypovolemia is there, patient will go to hypovolemic shock, which involve all parts of the body, starting from the brain. In hypovolemic shock, take the example of kidneys. Kidneys tubules are not getting adequate nutrition, the oxygen. So what will happen? There will be acute tubular necrosis. What will happen?
Acute tubular necrosis.
Keep on writing also. Anyway, all listen to me carefully, whatever it is. Acute tubular necrosis. Acute tubular necrosis. And patient might go into a renal failure. I am talking about those patients who are not in the hospital. I am still talking about if there is a delay in bringing out the patient. So what will happen? One thing, acute tubular necrosis and renal failure. There will be no urine output. How much generally is the urine output in 24 hours? It is 1.5 liters. 1.5 liters. There is an insensible loss from the body also, which is 15 ml. 15 ml per square meter surface, right? 15 ml per square meter surface. But in the case of burns, the fluid loss may be up to 400 ml per square meter surface, body surface, right? So, ultimate problem will be the hypovolemia. Once there is a hypovolemia, so all organs suffer, acute tubular necrosis and renal failure in the case of kidneys, and urine output will come down, and if it comes down, how much? It should be the How much should be the urine output? 1.5 liters. I will repeat again when we are talking about treatment aspects. So minimum patient's urine output should be one adult 1.5 ml per kg per hour. What did I say?
1.5 kg.
Urine output minimum should be 1.5 ml per kg per hour in 24 hours. What does that mean? A person who is 60 kg, how much his urine should be? That means per hour 1.5 ml multiplied by 1.5 ml multiplied by 60. That should be the hourly urine output. And 24 hours you can make out 24 into this thing. Alright? So 1.5 liters. If you have resuscitated a patient, given him fluids, and urine output goes to 2 ml per kg per hour, 2 ml per kg per hour, if it exceeds to the 2 ml per kg per hour, that means he is being overhydrated. Then you can restrict the fluid, right? It becomes watery and things like that. So kidneys are affected, the intestine will be affected. Intestinal ischemia will be there, not getting, because hypoperfusion is there, so the intestine are more prone to infection in the absence of proper oxygenation and nutrition and perfusion. So there will be infection there, and there will be another problem. What else? When there is ischemia to the gut, what can happen? The person might develop ulcers, and if it is in the duodenum or the stomach, patient may start bleeding, and bleeding from the upper GIT, when he throws out as a vomit, the blood vomiting, it is called hematemesis. What is this called? Have you heard about hematemesis? Suna? This is named as a Curling's ulcer. What is it called? Curling's ulcer is a direct complication of extensive burns. Because of ischemia of the gut, the person develops gastric erosions, mucosa is affected, is destroyed, and he starts bleeding hematemesis. He has not been brought to the hospital, but all these complications are occurring in some people. Right? What else can happen? What other organs can suffer? A person who has to trapped in a fire home where there is smoke going on, so he is doing what is doing? He is inhaling. What is he inhaling?
Smoke.
He is inhaling smoke. And what does smoke contain? Carbon monoxide, the soot. So what is the problem? Now what will happen to the respiratory tract? A person who has been exposed to fire is confined to that. He has not been brought out, he will die. Why? Because he'll have asphyxia. You know, asphyxia is the cutting off the oxygen supply. It's an entire smoke. Dreadful. The person will have, it is a miserable thing. Patient is struggling for breath. He is standing there. There are flames, there are heat, and he is inhaling smoke, carbon monoxide, soot, chemicals, and things like that. So there are injuries to the upper respiratory tract most often. Above the larynx, supraglottic, lips, oral cavity, trachea. You get my mind? Larynx. So mucosa is, what happens to mucosa? There is a swelling. There is a swelling, there is a ischemia, and this sloughs off. The mucosal layer sloughs off, goes down and blocks the respiratory tract doors. There is edema. So there is airway obstruction, which is a gross emergency. What is that? What will happen? Airway obstruction. You know about ABCDE of ATLS, Advanced Trauma Life Support. You have heard about it? What is that? Advanced Trauma Life Support. That is A is for when we treat a person with In a trauma, we have to allot priority. So A means airway. Airway should be patent. And in injuries there, you should avoid that he does not have cervical spine injury. If you start managing the airway obstruction and you have not taken into consideration that person has got, might have cervical spinal injury, he will have quadripariesis or he might expire also. Yes, sir. Right? So airway means you clear the airway. That is part of the management, not at this moment. I'm not talking about it. So airway, breathing. Airway is okay, but person is not breathing because there will be injury to the lungs and pleura, and there are so many things. The pneumothorax, open pneumothorax, tension pneumothorax, plane chest, cardiac tamponades, and things like that. I am reciting you these names just because whenever you read, you will remember my words. That yes, it will strike you. You have forgotten about it, but if somebody talks to you, cardiac tamponade and things like that, so then you will remember. So what I mean to say is that due to smoke, that person in his suit also, which it causes that go down into the alveoli in the lungs, right? And in patchopacities and etc. you might see, and gas exchange is affected at the alveolar level. There is a fluid inside the alveoli which is not breathing. It goes into respiratory level, right? So a person with that kind of, he will be having cough, forces of voice, there will be pain, and he might have, lot of this thing also, screeches also coming out. And the breath sounds are altered. So upper respiratory tract and lower respiratory tract is involved because of the smoke, and in absence of oxygen, what happens is hemoglobin's job is that oxygen combines with the hemoglobin, right? But then carbon monoxide gets attached to the hemoglobin and level of carboxyhemoglobin will rise. What will happen? Level of carboxyhemoglobin will rise. You might have heard that some people, they used in older times, they used to keep their homes warm by, burning coal at night. People have slept, they have closed the doors when it's snowing outside. When it snows outside, people used to burn coal, and that used to contain carbon monoxide. And in the morning, you find they are pink red and they are dead. And some people, if they are lucky, they get up and then, those people, the experience says they get intense headache and things like that. So carboxyhemoglobin kills the person, right? So as a net result, it's already I've written over here that it is basically the fluid loss. What is that? Fluid and electrolyte loss. Sodium is lost, potassium is lost, water is lost, proteins are lost. And with this kind of a problem, patient will go to shock. Now, what can we do about it? Investigations are being done. So the fire has set, what do? उसको बुझाएंगे हम लोग. The fire has to be extinguished. But a person who is on fire because of flames, you shouldn't be running around and standing. You should be immediately put down.
On the floor.
And the fire should be smaller. The fire should be extended. Whatever you know, you find, extinguish it with that. आपको बुझा दो. Is that right? And take out his clothes. If you keep the clothes intact, the clothes are burning. It continues to get.
Stick over the skin.
They'll get due to the skin because it's melting and things like that. They'll get fixed to that. But one thing is there, that burning clothes must be removed at once. Otherwise, patient extent and depth of burn injury will increase. Here also I want to tell you that there is some household, some kind of a contact with the electric wire, naked electric wire, and toddler or somebody catches it, he conducts this electricity. He may have cardiac effects, cardiac arrest, God forbid. And there will be contact point, entry and exit point. Superficial, the skin might be absolutely intact. What did I say? Somebody touches a live wire. The current is being conducted. Low tension, high tension. At household, it's a low tension. But person catches the high tension wire. Now it goes into spasm. It's a kind of a technique. Spasm, muscle spasm is there. He grabs the wire and he cannot release his hand. And the damage is done. So therefore, the other person who it has happened, he tries to remove the wire, he also gets electrocuted. You get my point? He is also electrocuted. So never do like this. Have a wooden stick or something like that, remove the wire. It should not be bent again. You understand what I'm talking about?
Yes.
Don't touch the electric wire at all. Or if you don't have any kind of a wooden stick or something, you've got a chair and just do that. Fling it about. You get my point? First and foremost is extinguish the fire. Right? Extinguish the fire. Smaller. With their coat, clothes and things like that. Even there is a carpet is there, something like that. And immediately pour cold water on the fire. What do you want to pour?
Cold water.
Cold water. Cold water. We are still outside the hospital. Patient has not been brought to the hospital yet. So what is the cold water? ठंडे पानी की बाल्टी डालो उसके ऊपर. And contact period to the cold water should be
2 minutes.
these figures you will never remember. 10 minutes. For 10 minutes, pour water. The person should have. Because this is a very good first aid. This is called first aid. You're doing something on the spot. But if you delay that, nobody's thinking, and because in our country, everybody is a doctor here in this country. Everybody. You go to the hospital sitting there, I've seen that. I go to sometimes I have to take my wife and I go to the hospital. It's very, very, sit down. I never put my weight along or something. The doctor inside is my friend, my colleagues. I never argue inside. I wait for it 1 or 2 or 3 hours. We take only 15 minutes or otherwise. I used to wait. When I was commanding a very big unit, I used to sit outside. In my own my wife and children used to wait. So what I'm trying to say is that time is a very important factor. And this is an emergency. So before patient is brought to the hospital, what do? You pour cold water and contaction with air and remove all the clothes from him. But if you delay it, the damage is done. Because cold water will prevent further injury, number one, and it brings soothing effect in the sense that the patient will have less pain. What will have? You are alleviating the pain of the patient. But you have to pay another attention when you are pouring cold water. And what is that? If there's a person has sustained burns at a high altitude, the temperature is minus 30 degrees centigrade. I have worked in that environment also and operated people in a bunker during war and things like that. So, hypothermia will kill the patient. On one hand, we have to save the patient from the effects of the heat. And the other hand, if you put cold water on his head, in a minute the water turns into ice immediately within 5 minutes. Not in 5 minutes, instantly. Water will freeze. So patient will die due to hypothermia. That is another thing. So first aid, I've already told you, put cold water, remove the clothing, extinguish the fire, and drag him on around, not running around. Now he comes to the hospital. Now what do we do? The patient has been brought to you. He should be sent to the burn center. Burn center. Burn center is the burn unit in which the persons who are inside, they cannot come out. The persons who are outside, they cannot go inside. So a person is given a, first of all, what do we do? First and foremost thing is, there is assessment is done. Airway is firstly we have to exclude that he does not have airway obstruction, that he is breathing. With all that thing, his clothing, his, One person put a cannula in his where? Veins. He's in hypovolemic shock. The veins are not available. What do you do then? What are you going to do to have an access to the veins? You are going to face these practical problems. So therefore, I will tell you one thing, that learn each and every procedure which would save the life of the patient. And what are these? I said airway obstruction. You must know how to intubate a person. Intubation. What did I say? Endotracheal intubation. And for adults, the normal size is 7.5 to 8 mm in diameter. It has got a cuff. You inflate it because it has gone beyond the vocal cords. You inflate it to 2 to 3 centimeters above the carina, should be the end, that you can access. Right? Endotracheal intubation to maintain the airway. You may treat the burn, but you have not done the airway of clearance of the airway obstruction. So you must know. I'm telling you right now, as a student, you should know how to intubate a person, how to put an endotracheal tube. That has to be demonstrated. I demonstrated to people just a few days back. So what we do, endotracheal intubation, cuffed endotracheal intubation, so tube will come out. So you cuff it, inflate it with air at its tip. You know, there is a ring, kind of a ring, there is a balloon. It will inflate. No, it cannot come out of the vocal cords. Right? The first thing you must learn is endotracheal intubation. Endotracheal intubation. And if you cannot put it, you just do a chemotherapy. Put a needle here. That will save his life. So I asked you, if patient requires fluid, he cannot eat or swallow something. Can he, a person who has got 80% burns, can he eat? He will be swollen. He cannot swallow. He is having vomiting. And veins are not there. There's nothing. So what do you do now? The veins are not accessible. They have collapsed. What do? You have to do central venous catheterization. What do you have to do? Central venous catheterization. Central venous catheterization. Must learn it. You learn it as a student. You should know it's a very simple procedure. You have an access to the internal jugular vein. You have to know the anatomy of a place. Otherwise, you will put the catheter, central venous catheter, into the carotid artery. And fresh blood will come out. It has happened with me. I told the anesthesiologist the blood is coming out. It's in the artery. Please withdraw it. It happened twice. Really. So you must know the anatomy where the internal jugular vein. If not, then you can do through the subclavian vein. You know, it's a very simple and interesting procedure. Anybody can do it. You have to see in the net how to do central venous catheterization. So put a catheter in the internal jugular vein or in the subclavian vein, and then you can push the desired amount of fluid and what fluid, that I'm going to tell you. So now you have put an airway, you put an endotracheal tube, you have put an intravenous catheter, or you have put a central venous catheter. You done central venous catheterization. Now therefore under anesthesia, patient is not going to give a nice good wash and wear. You may have to remove all the debris, clothes and things like that. Right? At this level only the patient's dressings are also done. Antibiotic dressings, antiseptic dressings. There are so many dressings, I'll tell you later on when we come to the dressings. And then what steps we do thereafter? Patient's pain has to be relieved. Patient's pain has to be relieved, and for all those patients, see, he doesn't require, everybody does not require endotracheal intubation, things like that. Everybody does not central venous catheterization. How? Where is central venous catheterization required? When a person, a adult, has got burns of 15% total body surface area. How much? 15%. Above that, a person requires IV fluids. And in a child, any child having burns of 10% total body surface area must be given IV fluids. How much? That I am going to talk to you. You must know that. And anybody having burns more than 5%, please admit it. Any person having burns 5% of total body surface area, please tell him he should be admitted. What did I say? Any person having 15% burns total body surface area must be given IV fluids, and a child in that case should be given IV fluids. So let us see what kind of fluid we give. Please note. Two things are there. One is crystalloids, another is colloid. Crystalloids and colloids. Two things are there. First 24 hours, even if there is extensive burn, we don't give blood transfusion. The person may be having, what happens to the person in extensive burns? There is a destruction of muscles also, so the person will have hemoglobinuria, myoglobinuria, and they will block the renal tubular cells causing renal failure. Hemoglobinuria, myoglobinuria. You get my point? So in first 24 hours, we don't give blood transfusion. Thereafter, when there is a perfect IV fluids are given, then the hemodilution, you can start with that. So formula for children is, suppose a child is 30 kg. How much fluid is given to this child? First 10 kg give 100 ml per kg for this thing, 10 kg. Child is 30 kg, weight is 30 kg. So how much we give? For first 10 kg, give him 100 ml. 100 ml. For first 10 kg, how much you give? 100 ml per kg. So how much it makes? 1000. Is it? A child who is 30 kg, we gave him 100 ml blood for first 10 kg. 100 ml per kg. For first 10 kg. For first 10 kg, we give 100 ml per kg. So it is 100 into 10, 1000. What did I say? A child who is 30 kg of weight, divide it 10, 10, 10, three parts you have to divide. First 10 kg, he should be getting 100 ml per kg for first 10 kg. 1000. Next, then you go for next 10 kg, you give 50 ml per kg. So it becomes 500 if I am not wrong. Right? So it becomes 500 ml. And now we are left with another 10 kg, giving 20 ml per kg for the last 10 kg. Right? So this is the formula, right, for a child. Whenever a child is brought to you with the burns, so now this is the 1000 ml, 500 ml, and 200 ml. So it makes about somewhere around 1700 ml, right? Right? Now, how will you, this is 24 hour quota. 24 hours you have to give him 1700 ml. So, what will be your drip rate for per minute? You calculate it. 1700 is divided for 24 hours. So 1 hour, how much you will get? 1700 divided by 24. And in children, please remember, 1 ml contains 60 microdrops. How much?
60 microdrops.
60 microdrops. घर में जाके calculate करना है. ठीक है? Calculate it. It's not very intricate. Listen to me. I'll talk to you. See, when you are giving fluid to a child, please give 100 ml per kg for the first 10 kg. Is that right? For next 10 kg, you give him 50 ml per kg. 50 ml per kg for 10 kg. And finally, for the third slot, you give him 20 ml per kg for 10 kg. Is that right? This is the quota for 24 hours. Is that clear? So, for 1 hour, how much you will? So, 1700 divided by 24. So that will give you 1 hour, 1 hour. That means 60 minutes. Now you are calculating now, you want to fix rate, drip rate. You have calculated that 1700 divided by 24 is the 1 hour. Now you want to build 1 minute. So 1 minute has got 60 seconds. So what should be the drip rate? Because 1 ml micro drops in children are 60 small drops, right? Okay? Are you understanding what I said? We calculate through. But for adults, we have got a formula which is called Parkland's formula. There's so many Evans formula, Muir and Berkeley formula. I am not going to confuse you, but you remember Parkland formula, one formula, and stand to it. Stand by it. Whenever you get a patient who's adult who has got 20% verbs, Parkland formula. What did I say? Parkland formula. The other formula, the Evans formula and Brooks formula, they make 6 slots of 4, 4, 4, 6, 6, 6, 4 hours, 4 hours, 4 hours, 6 hours, 6 hours, and then 12 hours. Each of these will be getting a fixed amount of fluid. I am not going to talk about that, but you see Parkland formula, I will tell you here. Listen to it. Usko kya dekhoge? What are you saying? Look at me. Parkland formula. What did I say? I am repeating again and again. People call me as a crazy fellow, but still, this is the only way I have been trained like that. Repeat again and again and again. Because you will go back, you will not read. I know that because there are so many subjects to read. You are not appearing for a final MBBS, so you have the final MBBS later on. So in Parkland formula, what we do is we calculate how much of the fluid. First, we assess what is the extent of burn. Suppose a person has got 60% burns. How much?
60%.
60%. So the total body surface area involved by burns multiply with weight of the patient and then further multiply it by 4. That is his 24-hour requirement. You understand what I said? The Parkland formula says that please assess first of all the total body surface area. Total body surface. I believe you are preparing for the next lecture, if I am not wrong. You are preparing for some other lecture? Very good. Total body surface area. Suppose a person has got 60% burns. Multiply it with his weight.
Weight in kg.
So weight in kg, that's right. So I stand corrected. Weight in kg multiply by 4. So it becomes how much?
60. And what is the weight of a person?
So according to a person has got 60% total body surface area. His weight is 60 kg. Multiply with weight in kg and multiply by 4. How much is this? 60 multiply 4? How? No.
Yeah, 14.
Yes, it's right. 16 into 60 is 3600 if I am not wrong. 3600. 3600 multiplied by 4. How much?
14,400.
You thought 60 multiplied by 60 is how much?
3600.
3600.
Into 4.
Into 4. Do the calculation again. 3600 multiplied by 4. Your multiplication is probably wrong. Absolutely right. 14,400.
400.
This much amount of fluid, 14,600. That means 14.60 liters. You can say approximately 15 liters of fluid you have to give in 24 hours. But then if you are pushing 24 liters of fluid into a person, if skin is intact, he'll overload him. Check that. So what do? You have already put an airway. You have given the central venous catheterization. Now put a urinary catheter also. Listen to me clearly.
False.
Follis catheter, self-retaining Follis catheter. And once you overloaded the person, you see the urine output will be more than 2 ml per kg per hour. That means you restrict the fluid. But technically, a person who has got 60% burns, his weight is 60 kg, he should get in next 24 hours 14,400 ml of fluid. Which fluid? This should be crystalloid. Ringer lactate preferably. And now, if you want to give a person 14 liters, I'll tell you one simple formula. So, that simple formula I'll tell you at random within 2 seconds you'll be able to catch that. So, if you want to give 14,400 ml in 24 hours, 1 hour, calculate 14,400 divided by 24. How much is that? Please tell me. 14,400 divided by 24.
600.
So 600 ml you have to give it in 1 hour. And how much? 600 ml. Are you sure?
Yes, sir.
600 ml you have to give it per hour. 600. You have to give it 1 hour. Is that right?
Yes.
Are you sure very much?
Yes, sir.
So if that is so, I agree. So 40,400 divided by 24, how much is it?
600 ml per hour.
600. 600 ml you have to give in an hour, but in minute how much you have to give? 600 ml divided by 60. So you have to give 100 ml per minute. How much you have to give? 100 ml per minute. यही हुआ ना? Isn't it? So 1 ml in an adult constitutes 10, 16, 20. It can be 10 drops, it may be 16 or 20 drops. So it can be 10 drops also, depending on the size of the this thing. Yeah, size of set का कितना how much is giving it written in the books 10, some say 16, some say 20. So suppose 20. So 600 ml divided by 600. So you one person, if it is 1 ml contains 20 drops, so further divide by 100 drops. You have to give 600 ml per hour. So if you want to give 600 ml per hour, तो 1 मिनट में कितना हो गया? 100 ml. So 100 multiplied, how much it means? You have to give 100 drops per minute, isn't it? Is that right? But simple formula is, if you want to give 1 liter of fluid to a person in 24 hours, 1 means 1. That means give him 11 drops per minute. How much? You calculate it. If you want to give 2 liters, give him 20 drops per minute. 3 liters, 30 drops. So if you want to give him then subsequently 1 liter, if you want to give him 10 liters, so keep the rate at 100 drops per minute. Right? So this is the Parkland formula in which the total body surface area, weight of the person multiplied by 4, that is in 24-hour calculation. Your business, your own this thing, how much temperature you will fix. Is that clear? Now next thing which comes is, I've already told you the pain relief, opium and things like that. Opioids, light opioids. You have to keep the patient pain free. Then you have to prevent infection. Because which are the infections which takes over in burn cases? 3 infections are very important. One is Staphylococcus and Pseudomonas. Staphylococcus, Pseudomonas. So, unless the patient has fever, if the wound is infected, then you give antibiotics. And barrier nursing. Barrier nursing means person should be fully covered with sterile gowns. A person having infection should not enter the burn unit, and nobody should be doing the trespassing. Right? And there's a laminar flow of air inside. Okay? So that is, and then the dressings. What are the dressing you do? You do the dressings with antiseptic solution and you are topical antibacterials. Topical, like silver sulfatazine. What did I say? You cover the wound with silver sulfatazine. Silver sulfatazine. Then there is a silver nitrate solution also, and silver sulfatazine, you can do the soframycin, you can do the furamycin, you can do the silver nitrate, silver nitrate also. So your dressings should be, topical dressings should be, the wound has to be covered with, one is absorptive, do a dressing in which the patient will be having exudation, lot of fluids is losing, you get my point? So you cover it with, there's another thing, another dressing is a paraffin gauze. What is it called? Paraffin gauze or sofratole. Soframycin gauze is there, it will not stick to the wound. Otherwise, when you're taking off the dressing, it will get some peel off and cause a lot of pain if you do the dry dressing. So you do absorptive dressing with Vaseline gauze or soframycin, cover it with a gauze, we said cover it with a pad and apply a sterile covering and examine the wound every day. If it's intact, well and good. But change the dressings frequently, right? What you have to do, apply topical antibiotics, which I've already told you. Is that right? And then, the newer type of dressings are that you do hydrogel and what do you call it? Hydrogels and hydrochlorides. Okay? These are also absorbents. So it will absorb hydrogels, they will absorb the dressing. And we have a closed system of drainage these days. We have a closed system of drainage, but when the area is vast extensive, you cannot apply the vacuum drainage dressings. So do the dressings with silver sulfatazine. You can do the povidone iodine, betadine, but that is very irritating. Betadine is patient complains of pain. Patient complains of pain. But so silver sulfatazine, paraffin gauze, sofratole, plenty of sterile gauze, gummy pads, every day you should do it, right? And you can use cultured keratinocytes also. Keratinocytes, you can keep in the refrigerator these cells, keratinocytes, which have been cultured and which should be stored at 4 degrees centigrade. Thereafter, what you can do? Now, patient is gradually healing. Now, nutrition is very important. What is important? Nutrition. But in case he has got an infection, give him antibiotics. For antibiotics, what antibiotic you should get? Send him a swab for culture and sensitivity. Take the wound swab, send it to the culture. Take a urine swab, send it to the laboratory. Take a blood culture, send it to the laboratory. And most, if you consider the most appropriate specific antibiotic showing sensitivity, please give them antibiotics, right? Generally, till the time the reports have come, you could start them on antibiotic which covers both the gram-positive and gram-negative organisms. Is that right? Next, what do you do? Dressings हो गया, antibiotics हो गया, nutrition. Nutrition, what nutrition? The patient, can he take food? No. But when he starts taking food, you have resuscitated him with IV fluids, and he started accepting fluids, you don't give him pure water, you will go into water intoxication. Alright? So you have to give us electrolytes which are balanced in the sense that you know oral rehydration therapy, ORS kind of a thing. He should start eating also. And the moment he starts eating, his mucosal integrity of the intestines will improve, right? So a person with burns will require, note down, the calorie, this thing. A patient, a burn patient, before I start telling you this thing and close my show, the patient will require, lot of calories and protein. Protein is given 1 gram per kg. If person is 60 kg, so minimum 1 gram per kg. Plus, if you go 30% burns, 3 grams per percentage of the burn. Is that right?
3 grams.
The protein requirement in a burn patient is, please listen carefully. Protein requirement in a burn patient is 1 gram per kg. Whatever. So 1 gram multiplied by weight plus 3 grams per percentage of total body surface area. What did I say?
3 grams per person.
3 grams for total body surface area. And over and above, he must take fluids. And how much fluids he will be losing every day? Quite a lot. And because of evaporation, he is losing 7,000 kilocalories also. How much he is losing? 7,000 kilocalories. You have that much of calorie. 20 kilocalories per kg multiplied by 70 kilocalories of total body surface area, right? And a person will be losing every day, one patient will lose half kg of weight. How much? Half kg of weight you have to compensate. And this is because he is injured, he has got sepsis, his catabolic rate will increase. What will increase? Catabolism will increase, he will require more calories and nutrition. So thereby he is not eating. So therefore put a nasal feeding tube. What do you do? Nasogastric tube. Nasal feeding tube. Put a nasal feeding tube through the nose, right? Or through the you have put it through the nose. Rile's tube it is called, Rile's tube. So a feeding tube has to be given to him. Is that right? And patient should be nursed in a sitting position. How he should be done? Semi-recovery. He should not be lying down, otherwise he will escalate. His breathing will be affected. No, make an angle of 30 degrees. Please remember, when you become doctors, you remember my what I said. Immediately it will strike you. When you see the burn patient, it will strike you. My words will strike you. Right? So patient should not be lying down, but he should be sitting. He will feel, you will feel it in a better way. He will breathe better. Right? So what I'm trying to tell you is that he requires nutrition and the fluids. Pure water intoxication should be avoided. And then what else you can do? What else further you can do? Physiotherapy, otherwise you will develop contractures. Physiotherapy, move your fingers, raise your hands, keep your hands above. You may have to split it also. Otherwise, a person with deep burns here, or the hand burns, you cannot do surgery immediately for that person. So there will be 5% will become near contracture. So split it in the position of function, glass holding position. Please split. Now if you keep the patient in the bed curled up, he has developed contractures, then he will be having both the knees bent fixed due to fibrosis. Avoid that situation. He should be given active physiotherapy and active movements, and hand should be raised, he should be in sitting position, and he should be given chest physiotherapy. Chest physiotherapy. But if a person has developed eschar, tuning effect, the burns are deep and ribs are affected, the muscles are showing necrosis, or they have become stiff. How is going to breathe? You have to put an area. Was there pressure ventilation, endotracheal intubation, and then he's on a ventilatory support. No, then what you have to do, there is an eschar here, there is a tunica effect. Immediately you see what you are doing, you cut it. You cut it longitudinally from top to bottom, so that his soft tissue expands and his circulation improves. Otherwise, he is going to have a gangrene. Your time in tunica, that means eschar is tough, hard structure, which is healing and is pressed down. Within 24 hours, good enough, his arm will be gone. And in chest, you give a longitudinal incision. In limb, you give a longitudinal incision. Please cut open it. And that process, person might bleed also, and keep the blood ready for transfusion. What did I say? Do not hesitate to give long incisions to the patient to relieve the pressure. Otherwise, this tight tunica will kill that patient. Do you understand that? You have to give hundreds of incisions. We have done it, and we have saved the people. We have long incisions like that. But taking care that you don't cut the nerve, you don't cut the vessels. Keep the blood ready. It should be done when? It should be done in the operation theatre. Right? And what else would you do? Now, lastly, what I am telling you, what else you can do? You can also do, I told you these dressings, you can put xenografts, Xenografts. What is that? The sports like skin. The skin of the animals, which has antigenicity has been removed. So they are very costly. They are very costly. In some of the places, afterwards, immediate grafts are applied, or immediately, urgently, skin grafting is done. The necrosed wound is removed. The dead skin is removed. The dermis epidermis, which is not viable, that is removed, and immediate skin grafting is done. And what is that? Split skin grafting. What is that called?
Xenografts.
No, xenograft is an animal skin. You know that own skin or things like that. Xenografts is this thing, what you call it, porcine animals, pigs and things like that. So that their grafts are taken. It's already made. There's a kind of a thing, and they are applied. But the color cosmetic, they heal very well. They do very well. Patient can be saved. 100% burns he can be saved. You know, it goes to tertiary care hospitals, and there they are doing it. Okay? So that is done. Okay. Otherwise, you can do a split skin grafting. Split thickness skin grafting. Split skin graft. That you take the skin from the patient itself, where there is healthy skin, and once you apply skin which is taken from the healthy part, the thigh or the back or somewhere, and is applied over the burn site. Otherwise, that ends, the catabolic response, and it builds up the patient, he recovers faster. Right? That is called skin grafting, which may be split skin grafting, or it may be full thickness skin grafting. Full thickness, then your fat has to be removed and applied there. That's very nice. Then another step is that you can do flaps. You cover the burnt area with the flaps. It's the later part. Otherwise, you raise the flaps from here with the intact supply, arterial and venous supply, and you lengthen that muscle, rectus muscle or something like that, wherever you want to transfer it to that place, or is a local flap or distant flaps, local. So if this part is injured here, so I will raise the flap from here and apply this. When we raise, it is attached to this area which has lost the soft tissue in the skin, local flaps. And then there are distant flaps also. Now finally I will tell you that once the wound is healed, what you do is, you must keep the donor side and the recipient, the Humby's knife. The knife which takes the skin graft is called Humby's knife. It's very interesting. The skin has to be caught raw. The paraffin is applied sterile one, and gradually surgeon takes a bite. Go and see in the net, everything is given. See in the net, skin grafting, Humby's knife. Not now when you go back to your home. So one person is there, he keeps the skin taut. See that? Skin is kept here, taut like this, and surgeon takes the graft. Right? This is called split skin graft through the help of Humby's knife. And finally, I want to tell you, whenever any patient comes to you whose wound has healed, keep the wound supple by applying liquid paraffin or coconut oil, something like that, and instruction. Thank you very much. I hope how you make my lecture. Did you give full attention to it?
Yes, sir.
Sure?
Yes, sir.
Okay. Thank you very much.
Thank you,
All right.
sir.
Okay. I close the show.